Okay, so today is Friday, and we're going to be covering chapter on diabetes. Um, so I believe it's chapter 20, if I remember correctly. So let me see if I can get that chapter. I left it somewhere here. There you go. Yeah. Okay. So chapter 20, acute diabetic emergencies. And remember that we live in an area where there's a lot of diabetes. So we're going to have to be dealing with some of this with stuff. Um, when we go pick up patients, even the patients that you're transporting to the house or whatsoever, probably do have a history of diabetes. Because it's so prevalent in this area and this well the valley. Okay, let's see. So as an introduction, just remember diabetes can actually cause changes in mental status related to alterations in blood glucose levels. So the brain relies heavily not just on oxygen, but on sugar, on glucose. And if you're not getting it, then your brain gets upset. Now, which is one of them is that you're not getting it because you don't have it. What would be another issue with you not getting sugar in your brain? Anybody?
Low iron levels.
I'm sorry?
Low iron levels.
No, no, sugar. Sugar's not carried by iron. Oxygen is carried by iron. We're talking about sugar here. And you're in the right path. Just know that, if you don't eat, you don't absorb sugars, right? That's
Mhm.
one way of not getting sugars to your brain. The other one is not having enough insulin in your system, or you have a system that does not accept the insulin that you already have, like an insulin resistance. So you might have a lot of sugar in your system, but it's not being taken into the brain. That was weird. So anyway, so that would be the other one. Acute diabetic emergencies are life-threatening. Remember, you run out of gas, your car stops. You run out of sugar, your brain stops. Okay. The other one would be if you have enough sugar, your body's not absorbing the sugar correctly because the insulin that you have is not doing its job. So that's what your typical type 2 diabetics. Okay. Problem recognition and care is critical. So in other words, we need to diagnose. Now, I want you to think about this. Remember what I told you? Too much sugar can kill you. Not enough sugar can kill you. The question is, which is going to kill you quicker, or which is going to kill you faster? So,
Not enough, isn't it?
yeah. So if you and that's the thing is that if you run out of sugar, you're going to die. So in one of them, you have low levels of sugar, also known as hypoglycemia, right? So let's just call it hypoglycemia. And the other one is known as hyperglycemia, high levels of sugar. Remember, hypo means low, hyper means high. You just by these words right here. Of course, you have glycemia. Glycemia, sure. So treatment wise, how would you treat hypoglycemia? How would you treat hyperglycemia?
Hypo, you give them oral. I
Yeah,
forgot what it's called. Glucose.
yeah, you give them the glucose or the glucogel. Okay,
Hmm.
so you give them sugar, right? If they're conscious, because if they're not conscious, you're gonna give them sugar. It's gonna go straight into the lungs, and sugar is a has high molecular structure. So when you have a molecule that's large, it's gonna attract water into wherever it is. So if you put it into the lungs are gonna drown in their own fluid because it's gonna be stealing water from the capillaries. So how about hyperglycemia? What do you do for hyperglycemia?
Insulin.
We can't give insulin in the field. And it's kind of scary because at one point they wanted to make a nasal type of insulin so you can give patients. Um, the question you have to ask yourself, how do the, if I find a patient and I know he's a diabetic, okay, how do I know if he's going through hypoglycemia or hyperglycemia?
You could do the blood. You test your blood.
Yeah, you can do a blood glucose test, okay, and it'll tell you. I know that I remember I took the glucometer, the personal glucometer I have. I took it to Mexico when I was running the clinic because the one that we had there had kind of like not working anymore. And I lent it to the other doctor that was there. And remember, we're student doctors, so he does the blood sugar levels. And he turns around and tells me, "Oh man, this machine that you got is very friendly." And I came, "What do you mean very friendly?" "Well, it's telling me hi." And I told this guy, "It's not telling you hi like hello. It's telling you hi. It's too much that I can't give you a number. So it's above 500." So, oh, I get it. So, I mean, I thought that was, I mean, every time I see him thinking, hey, I just got another one, and it does tell you high also. Uh, but let's see if you don't have a glucometer or the battery ran out or you ran out of those sticks. What do you do? How would you treat a patient? Or would you treat him at all if you don't have a glucometer? Hmm. Ideally, what you want to do, guys, if you don't know the sugar content in the system, uh, assume that he's going through hypoglycemia because hypoglycemia will kill you a lot faster.
Okay. So there's no. I thought there was like a way to test it in the field if you didn't have it. Like
Well, I know that when I was in running one of the clinics in Mexico, they had told us, "Oh no, have him go pee outside in the tree and have him come back the next day, and if it's full of ants, then he's hyperglycemic." I mean, and it does make sense because once your sugar levels reach 180 millimeters, I mean, deciliters per deciliters, that would be blood pressure. I'm sorry, uh, millimeters of sugar, then the kidneys themselves will actually release urine with sugar in it, so they can kind of bring down. And ideally, the way I like to see it, a lot of the medications nowadays that diabetics are taking helps them pee, so they can actually release some of the sugar through their kidneys. But in this other case, if it reaches that amount at 180, then the sugar is automatically gonna, those dams that the kidneys have to prevent sugar from escaping first, and you're gonna pee a lot of sugar. So that kind of made sense. But you don't have in EMS, we don't have more than 10 minutes. So you assume that they're hypoglycemic, and if they're conscious, you give them oral glucose, because a little bit more sugar is not gonna kill them. These guys that are hypoglycemic, they will die eventually, but very slowly. They'll cut one toe 1 month, and then eventually they might actually cut the whole foot, then the leg, or they might go blind, uh, and whatsoever, right? But it's not gonna happen very fast. But with hypoglycemic or hypoglycemia, they will die very fast. So ideally, if they're conscious, you can go ahead and give them the oral glucose, and it's absorbed very quickly. But if you don't want to bleed that, and always call ALS backup just in case, because they can actually give. I don't know if your protocols state that you can actually give glucagon, and glucagon is actually a hormone that will actually cause the body to release whatever sugar it's got stored at a slower pace. But it will, whatever you stored. So, of course, and it does mention here that diabetes has serious long-term complications. Okay, under normal circumstances, hormones control the blood glucose levels. Diabetic emergencies result from the abnormalities in blood glucose levels. And the blood glucose levels are controlled by insulin, and believe it or not, they're also controlled by glucagon. I think another one of them is you have epinephrine also affecting it, and also I think it's growth hormone. So glucose basically is a sugar. Carbohydrates are the primary energy source for the cell. So let's say if you decide to eat a hamburger today, if in a few hours the body's gonna break it down to its simplest sugars. Okay, there's a couple of other things like peptides and whatever, but sugar is what your body's gonna break everything. I know when I was working in the chemistry department, uh, one of the professors had taught us on how to make alcohol from wood. So you break down stuff enough, eventually you're gonna get to the elemental stuff. So complex carbohydrates are broken down into simple sugars, primary glucose with a use for use by the cells. Remember, glucose is used by the cells in the mitochondria to make that process of uh, what's it called? Oxidative phosphorylation. Okay, so glucose regulation. Regulation of blood glucose levels is critical for normal cells to function. Brain cells can only use glucose for energy and cannot function when glucose is inadequate. Low blood glucose level results in altered mental status. And prolonged low blood sugar levels leads to brain cell death. Glucose, excess glucose in cells causes water to enter the cell, which worsens head injury or stroke. So remember I told you that sugar is a high molecular structure. And when you have a high molecular structure, it actually water tries to follow it because it kind of gets sucked into it. So if you have a lot of glucose levels in your brain, but it's not being utilized because you have an issue with not being absorbed into the cells, then that I don't want to say interstitial, but the fluid that you have in the brain or the plasma is going to be sucked into the tissue, and is going to cause head injury because you're going to have too much water in the system. I mean, in your brain. With high glucose levels, glucose is excreted in urine, bringing water along with it, leading to dehydration also. So one of the key things that you have to remember is that diabetics sometimes get dehydrated, and we'll talk about that condition in a little bit. Hormones can also control blood glucose levels. Insulin is secreted when blood glucose levels are high. So insulin is secreted by specific cells in the pancreas, and the pancreas has these little areas that are called the islets of Langerhans, and those actually contain three different cells that produce three different I want to say structures, but hormones. One of them is growth hormone. The other one's going to be insulin. And the other one's going to be glucagon. So without insulin, little glucose can actually enter the cell, so they don't function, and glucose remains in the bloodstream, resulting in elevated blood glucose levels. So at this point, you have glucose movement into the cells with insulin and the inability to of glucose to get into the cells without insulin. So ideally, whenever you have a glucose structure going in, it's actually facilitated in through these little openings that the cell has uh, that insulin actually opens up so sugar can actually go inside. And it starts producing energy when it starts mixing up with, what do you call it? When it starts mixing with oxygen. So you have hormones actually control glucose levels. One of them was insulin. The other one is glucagon. It's secreted when the blood glucose levels are low. So insulin is secreted when blood glucose levels are high, but glucagon is secreted when blood glucose levels are low. So they're antagonistic to each other. It functions to increase and maintain the blood glucose levels. Also, the main function it has. Yeah. Other hormones, epinephrine. This is not released in the pancreas. Epinephrine is actually released by the suprarenal glands. And if you don't remember where the suprarenal glands are, oh, I just messed up. Hold on. You just remember you have your kidneys. Okay. And right on top of the kidneys, it's got like a little cap. I call it the beanie of the kidneys. Okay. And this is where epinephrine is actually produced. So basically, uh, it's get released when blood glucose levels are very low. It inhibits insulin secretion. So what it does, it stops insulin from being secreted and promotes the release of stored glucose from the liver. Okay, so ideally what happens is glucagon it's an antagonistic hormone that will actually work against insulin, and it shuts it down. And what happens is that it also turns around, and uh, whatever sugar you actually have stored, specifically in the liver, it gets converted from glycogen to glucose. Now, have you all ever heard of hepatitis, the disease? Hepatitis, guys. Guys, you guys have to get your 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 immunizations for hepatitis.
Wait, what
Hep-
did you call it before, sir?
hepatitis. A hepatitis
Okay.
basically it's inflammation of the liver. And I'm gonna tell you some correlation that I had. I had an epiphany one time when I was studying this when I was in medical school. But basically, the hepatitis is basically the inflammation of the liver itself. And I remember when I was little, my sister was exposed to hepatitis. So everybody in the family had to get shots. I didn't have a problem with it, but when my dad was trying to put the shot on my sister, she ran like a wild rabbit, and you can catch it. We actually had to knock her down and give her the shot. But good thing is that they gave us hard candies. Like what do you call those Jolly Ranchers? the lifesavers or whatsoever. They gave us candies because I believe when your liver gets inflamed, it doesn't release the glucose that you need. So you constantly have to be eating sugar to get, I mean, not in the form of chocolate, but sugar in the form of hard candies. And I thought it was kind of weird because, but they're giving us sugar. I mean, why are they giving us sugar, And I thought it was like, oh, you got the shot, here's your price. But no, it's because of that. Because once the hepatitis hits, what do you call it? The liver gets inflamed and it doesn't release glucose, the stored glucose that you have. So you have to also remember, how many times do you guys eat a day? Well, besides Eddie, a normal person, how many times do they eat a day?
3 times.
About 3 times, right? And when's the
Okay.
last time you eat in the morning, at noon, and in the evening, right? So let's say
Yes,
you
sir.
eat dinner at 6 o'clock. Okay. What's going to keep your sugar levels normal during that fasting period that you're going to go through after 6 o'clock to 8 o'clock in the morning?
Your
Water.
liver?
Well, the liver itself, I'm sorry, it releases the stored glucose that it has. So it keeps you alive. Did you guys know that?
No.
Of course, if you're like me, dude, I wake up at 3 o'clock in the morning and I'm looking for a damn chocolate bar. And I've always done that. So, but normal people, not EMS people, normal people eat 3 times a day. And they have that fasting period from about 6 o'clock to about 6 or 7 o'clock in the morning. So that's how you actually stay alive. Your glucose is actually being released by your liver. And basically, some signs and symptoms of hypoglycemia are related to the release of epinephrine. So also when you guys release, well, we don't release epinephrine, we release adrenaline, which is the same thing as epinephrine. We actually what do you call it, become hypoglycemic because of that. Like when we get scared. Normal metabolism of glucose regulation, the normal range of glucose is 70 to 120. Now, this kind of varies a little bit because some hospitals will have 70 to 110 or 80 to 120, but they're on that range. And I remember I read an article at one point that they wanted to bring down this top number 120 to 100. And the reasoning behind that is that you can actually catch people that might become diabetic a lot faster because now at the numbers at 100. I don't think it happened, but I remember that it was going through. Insulin is secreted in response to the increase in blood glucose levels, and between meals, blood glucose levels drop. Glucagon is secreted to increase and maintain blood glucose levels, like what happens at night, unless you're like me and wakes up at 3 o'clock in the morning and start eating. So basically, the glucose regulation, you have normal glucose regulation. You eat a meal, eventually the blood glucose levels increase 120 to 140 milligrams per deciliter, and then insulin gets secreted, and then causes cells to uptake glucose liver and creates glycogen. So basically, as your insulin is using up that sugar, it's dropping, and then glucose levels, the liver actually starts creating glycogen. And basically, once you get about, the glucose levels about 70 milligrams per deciliter, glucagon gets released. And glucagon, remember, stops insulin from being secreted. So once glucagon gets secreted, it stops insulin from getting secreted, so the blood glucose levels don't go down. But glycogen now is produced, it produces glucose, which is non-carbohydrate produced glucose, And what happens is that your blood glucose levels actually go up. Just remember, glucagon stops the secretion of insulin, which kind of regulates it. And you're running 120 to 80, depending on the day. When you eat something, of course, it goes a little bit higher. Abnormally, glucose regulation in diabetics mellitus. Now remember, this another thing is that we have different types of, by definition, diabetes or diabetic emergencies deal with, it's not, diabetes is not a sugar problem. Diabetes is a urination problem. And we'll get into why I say that. But what happens, we have diabetes insipidus that does not have anything to do with sugar. And then we have diabetes mellitus, which is this one. Okay. And diabetes insipidus is basically the lack of release of a certain hormone in your brain to tell the kidneys to urinate. So if you don't have an inhibitory, something that inhibits the production of urine, inhibits, which basically means stop, you're going to be urinating constantly. So ideally at this point, you have the glucose regulation diabetes mellitus. So you have glucose regulation diabetes, you eat a meal, of course, the blood glucose levels go high because you just ate something that's going to be produced. Now, insulin gets secreted. Now, for whatever reason, whether it's secreted or not, in a type 1 or type 2 diabetic, it might be that it's secreted, but it's not being absorbed by the cells. So the cells don't uptake the glucose levels. So the blood glucose levels drop. Then you have glucose secreted. Then you have glycogen is actually secreted because of the production of glucagon, and blood glucose levels kind of get semi-controlled, but it goes high. Okay. Taking blood glucose levels, testing the blood glucose levels with a glucose meter, also known as a glucometer. Normal readings should be 80 to 120. When interpreting the reading, determine the last time the patient ate or drank something. It's very important because if you eat something, and you do the test, your blood glucose levels are going to be high. So you have to take that in consideration. Don't automatically call them a diabetic. I know that when you deal with pregnancies, they do a glucose test on pregnant females. And what happened, they actually, I was freaked out because I remember when I was going through the medical school, that thing is actually syrup. They give you a little drink and you drink it, okay? And it's just pure concentrated evil sugar. So your blood glucose levels go high, they shoot up very fast, but they want to see how fast they drop. Okay, and if they don't drop fast enough, then there's an issue. So hypoglycemia is blood glucose levels of 70 milligrams per deciliter or less with signs and symptoms. And hyperglycemia is anything above 200. Testing for blood glucose levels with a glucometer. Basically, the first thing you want to do during the day before you actually do anything with a glucometer is you want to test it with a strip that is specific. So you'll have a strip in there with an amount of sugar, and I'll tell you, if you put this strip in the machine, it should read 140. So you're calibrating the machine to make sure it's working. So what happens is that you clean the site. Normally you go on the lateral side of the finger. You don't go right on the top. You go on the sides of the finger. You clean it with alcohol. You put the little strip in the machine. Okay. Then you actually poke it with a lancet. And then you wipe down the first layer, and then you squeeze the finger so you can actually get a drop of glucose, and then it gets absorbed. It should take maybe like 5 seconds, and it'll give you the glucose levels that the person has. Now, diabetes mellitus, which is the normal one that we deal with, is a disturbance in the metabolism of carbohydrates, fats, and proteins. It results from lack of insulin secreted from the pancreas itself, or the inability of cell receptors to respond to insulin to allow glucose into the cells. So that's what we call insulin resistance. Your body has become resistant to insulin. Now, I know that the first thing that doctors do whenever they find that your glucose levels are going high, they want to go cheap. They want to go for the cheap treatment, and they'll tell you something like this: lose 20 pounds, and then we'll check you again. Because a lot of times all that extra fat covers up those receptors and don't allow it to work. So you lose 20 pounds, you might actually get normalized. So diet is the first line of changing a diabetic's readings. The patient has a high diabetes mellitus. The patient has a high glucose levels, but the cells are deprived of glucose. So there's a lot of sugar, but that's not going into the cells because the cells are not accepting the insulin, or you're not producing enough insulin. The brain cells do not require insulin to use glucose. Excess glucose is excreted by the kidneys, causing excess water loss. Now, this is the first thing that when we're talking about symptomology, this is the first thing that we find. Okay, excess water loss. So once your blood glucose levels are high, your kidneys are going to release that sugar, and it's going to be followed by water. So you're going to have this thing. It's called poly, which means many, urea. Many urinations. Urea means urine. So diabetics tend to pee a lot. And if you pee a lot, like in polyuria, if you pee a lot, do you think you might be thirsty?
Yes.
Yep. So because of polyuria, this leads to polydipsia. Dipsia is drinking water. So now you have two signs and symptoms that you're gonna look for: polyuria and polydipsia. Now, if sugar is not being absorbed into the cells, do you think your brain's gonna say, "Hey, wait a second, how come we don't have enough food? Let's eat more"? That is called polyphagia. So now you have polyuria, polydipsia, and polyphagia. I said polyuria, polydipsia, and polyphagia. So that's basically excessive urination, excessive thirst, and hungry. Does that make sense?
Yes.
Because you're gonna you look into that, from these patients. You have to. So patients have enough high glucose levels. I'm sorry, the next one, sorry. Okay, diabetes mellitus, you're gonna have polydipsia, polyuria, and polyphagia. The 3 Ps for diabetes. Type 1 diabetics, the pancreas does not secrete insulin. So now we have the difference between not only, let me see if I can get my little magic pen. Not only in diabetes, insipidus, which you have excessive urination because of the lack of the hormone that's in the brain that causes you to stop urinating. Okay. You also have diabetes insipidus. I'm sorry. We don't have that. It's diabetes mellitus. I'm sorry. So these are the two major kinds of diabetes: diabetes insipidus and then diabetes mellitus. And diabetes mellitus can be broken down into type 1, diabetes, and then it can actually be broken down into type 2. Type 1 is insulin dependent diabetes mellitus, or also known as IDDM. Insulin dependent diabetes mellitus. Type 2 is non-insulin dependent diabetes mellitus. Okay, so we have type 1 and type 2. We're talking about type 1 diabetes, which basically the pancreas does not produce insulin. Okay. And when it doesn't produce insulin, you become insulin dependent. This used to be known, type 1 used to be known as child onset diabetes. And type 2 used to be known as adult onset diabetes. So with age, you develop type 2, but if you're born with it or you had some type of issue where you had an autoimmune problem in your system that killed all your beta cells in your kidneys, then you develop type 1. But normally child onset was IDDM or type 1. Adult onset was NIDDM or type 2, which is not insulin dependent. And ideally type 2 is easily taken care of by diets or pills, okay, to control your diet, the absorption of sugar into your system. Type 1, you're getting sugar, but the problem is you're not producing any insulin. So patients must take insulin to regulate blood glucose levels. The peak onset is between 10 to 14 years of age, and patients often have a lean build, in other words, they're skinny. Patients are prone to diabetic ketoacidosis. Now, diabetic ketoacidosis, also known as DKA, diabetic ketoacidosis, is basically when your body cannot use sugar. Okay? Your body cannot use sugar because it doesn't have a good insulin. Okay, it cannot use sugar. What it does, it goes to something that we call fat metabolism. Now, how do we produce fat, guys?
Um,
Do we produce fat? Our diet?
Yeah. So basically, we eat food, and whatever we don't use gets stored. So you can easily say, without shaming anybody, if you eat a lot of food, you're gonna be fatter. Because whatever your body doesn't use, it stores it as fat. So it's a form of fuel. Okay, so when we're in a diet or we're exercising, so what are we trying to do? We're trying to burn fat, right?
Yes.
Now, you know that I remember there used to be a diet back in the day called the Atkins diet. Then this new diet that's out there called ketone diet or whatever, basically is based on that. And I remember I tried the Atkins diet, And what you would do is you would eat just meat, just protein, no carbohydrates. You couldn't eat bread, you couldn't eat anything. And I'm telling you, after about a day, my body, I was weak. I had a hard time because I wasn't providing my system with sugar. So if I don't have sugar, it starts getting it from somewhere else. And it starts getting it from the fat that I have stored. And the fat that I have stored is used up, which causes me to lose weight. But the only issue that there was with that diet, you developed ketoacidosis. So you would have to get a little strip, okay, and urinate on it. And if it turned a certain color, you were producing ketones and acids. That's a byproduct of fat metabolism. You produce ketones and acids. Okay, so type 1 diabetics produce this because they give themselves insulin, which sometimes lowers their sugar levels very low if they don't eat or they don't eat correctly or they have another issue. Or like they took twice the dose or whatever, right? So they start developing ketoacidosis. And ketoacidosis, the body tends to actually get rid of the ketones and acids. So you start having a fruity smell in your breath. Because ketones will actually give you a fruity smell. I remember a friend of mine used to call it the tutti frutti smell, but only because we had gums that was tutti frutti. I don't think they sell anymore. But he used to call it the tutti frutti smell. Now the issue is that, so once you start smelling this, you have to assume two things. If you have a patient that is stupidus, in other words, they can't keep their balance and they kind of are slurring their speech because of lack of sugar in their systems, what are you going to suspect? And they have a fruity smell on their breath that they've been drinking alcohol.
Diabetes.
No, actually, well, if you're an EMT, yeah, but if you're a police officer, you're gonna think this guy's drunk. So what do they do with drunk people?
Send them to the tank.
Send them to the tank and have them wake up the next day, right? But if they're diabetic and they're going through a ketoacidosis situation, they will wake up. They will wake up dead if you can actually do that. And I know that there was a couple of cases I know when I was working in Mass where we were called to the jail because the guy went unconscious, and we found out his blood glucose levels were at 20, which
Is that why police? Is that why police? Like it's super common for police to call EMS for a care check with drunk drivers.
Yeah, because you never know if they're diabetic. Now, in certain areas of the country, I guess it's more often that they actually have those little wristbands, or they actually have what do you call it, tattooed saying I'm a diabetic. I know that one point the police department was trying to, how you license that says little strip in the back, magnetic strip, that they keep that information in there. So when they swipe it, it tells them you're diabetic. Now, of course, if they find you outside a bar, come on. Oh, I'm sorry, I'm a diabetic. Don't throw me in jail. Now, back in the day, also there used to be a lot of these uh, drinks like Zimas or whatever. They were basically what do you call it? Kind of a fruity type of alcohol. I don't know if they still sell them, but anyway,
Like
so
MD40s.
I don't know what because you can smell beer and then you can smell ketoacidosis. So just be careful with those because you might actually get one of these. You might get called to one of these patients. Okay. Now, diabetes mellitus type 2 diabetics, the patients have oral medication like glucophods, also known as metformin, and all these other medications. They're actually in a diet and they exercise rather than insulin. So eventually, the body gets used to the pills that you're taking. Okay, they develop what we call a tolerance, so they're not going to work. So you're going to have an increased amount of that. So ideally, it's very important that you lose weight, you exercise to manage your blood glucose levels. Now, I always said, everybody everybody has a propensity to actually become a diabetic. Everybody becomes a diabetic. It just depends on when you want it. I remember when the doctor asked us that, when do you want to become a diabetic? And I told him, after I die from a long life. But then, depends on, the type of, diets that we have. Okay, so patients are usually middle-aged or older. Remember, it's an adult onset and overweight. Patients are prone to hyperglycemic, hyperosmolar, non-ketotic syndrome. So what does hyperosmolar remind you of?
Hypoglycemia.
Hyperosmolar. When you're dealing with osmoles, basically that's the movement of water from one compartment to the next. So if you have a lot of sugar in
Oh,
your system,
hypertension.
it'll give you hypertension. But these people become dehydrated because whatever fluid they have in their blood is being directed somewhere else. So if you do a 10 test on these guys, they're going to be positive for that 10 test. Now, whenever you find a patient like this, and I know that was a question that we had in one of our medical boards, what do you do? How do you treat them? Well, believe it or not, insulin and sugar is not as important as giving them fluids. So the first line of treating these guys is to actually give them fluids. Diabetics are prone to diseases and disorders in blood vessels, so they can actually get a heart attack, a stroke, and kidney failure. Okay, question. Click on the action below that results from a release of insulin. So once your body releases insulin, does glucose enter the brain cells in larger quantities than required for cell metabolism? No, because brain cells don't require insulin so they can get sugar. Glycogen in the liver is broken down into glucose, increasing the blood glucose levels. Well, no, because that's the result from getting glucagon. The rate in which glucose is taken up by body cells increases. That could be it, because your body releases insulin, the glucose is going to be taken up by your cells, bringing down your blood sugar levels. Or epinephrine levels are increased, leading to tachycardia, pale skin, or sweating. Nah. So it's going to be letter C. Okay, hypoglycemia usually occurs in type 1 diabetics. And why does type 1 diabetics develop hypoglycemia?
Because they're usually low in sugar.
Yeah, because they take too much insulin, they forgot to eat, or they vomited right after they took their insulin. So, anything that will actually cause sugar not to be absorbed. And if there's not enough sugar being absorbed, your insulin levels, whatever storage you have, is going to bring it down. So hypoglycemia is caused in type 1 diabetics because of insulin, the insulin that they actually take. Pathophysiology of hypoglycemia. The patient takes insulin but does not eat a meal. Patient takes insulin, eats a meal, and drastically increases their activity. They start exercising. Or the patient takes too much insulin, or it can also occur in type 2 diabetics from the effects of oral medications, which basically, it's kind of hard to maintain your sugar levels when you're trying to take medications that will bring them down. Okay. Assessment findings in hypoglycemia. You have altered mental status occurs from low blood glucose. Other signs and symptoms occur from epinephrine release. Remember, epinephrine will actually increase the glucose absorption, but it also gives you what we call a sympathetic response, where you start sweating, you get tachycardia, start breathing faster, and whatsoever. Assessment findings, basically you're going to have a patient that might be confused, disoriented, or drowsy, might be unresponsive, they might actually be having seizures, or they might actually have a stroke-like symptoms. Hypoglycemia unawareness. Okay, over time, the signs of symptoms of hypoglycemia change. This can allow blood glucose levels to drop significantly without intervention. Excuse me, without intervention. The other way. Emergency care for hypoglycemics. How do you categorize the patient? Either unresponsive, unable to swallow, or unable to follow commands, or altered mental status but responsive. In other words, they're awake, able to swallow, and able to follow commands. So in other words, unconscious, non-unconscious. For patients who are unresponsive, unable to actually swallow, or unable to follow commands, establish an open airway, apply oxygen to maintain an SpO2 level greater than 94%, but you apply it if it's below that. Provide positive pressure ventilation if breathing is inadequate, assess blood glucose levels, and request an ALS backup. Okay, for patients with altered mental status, but responsive, able to swallow, and able to actually follow commands, ensure the patient's airway, assess blood glucose levels, and administer oral tube of glucose or active the glucose. I think it's what is it called? Glucose, and the other one is no, it's not. That's Intachar is the other one. But
Insulin?
anyway, I'm sorry.
Were you naming the medication?
Yeah, the little toothpaste looking medication, insta glucose also. Oral glucose gets absorbed quickly, increasing the blood glucose levels. Oral glucose may actually be administered only if these patients' conditions are met. They have altered mental status, have a history of diabetes controlled by medications, or a blood glucose level less than 70. Remember, that's a low number, or has the ability to actually swallow. And basically what you do is you basically put it in between their teeth and their cheeks, and it'll get absorbed right away. There's intranasal glucagon. Glucagon does not contain glucose. It converts glycogen in the liver to glucose. So this is another way to actually increase the blood sugar levels. Administer via a mat or syringe, where basically just it's an atomizer into the nasal cavity. May take up to 13 to 16 minutes to work. It's a little bit longer lasting. But now you have your system working for you. So hyperglycemia is high glucose levels caused by a relative lack of insulin. So if you don't have insulin, or it's not working correctly, then your blood sugar levels are going to go high. Extreme hyperglycemia may result in diabetic ketoacidosis. So, and I think this is not worded correctly, because extreme hyperglycememia doesn't result in diabetic ketoacidosis. Well, maybe it is worded correctly. You have, hyperglycemia, diabetic ketoacidosis, I'm sorry, is a result of hyperglycemia. You also have hyperglycemic hyperosmolar non-ketotic syndrome, which this is where you become dehydrated. Okay, let me see. Okay. Hyperglycemic condition, diabetic ketoacidosis. Pathology of DKA, the blood glucose levels typically are above 350, okay, milligrams per deciliter. Without insulin to help move the glucose into the cells, and the cells get starved, cells actually begin to actually burn fat, which burning fat produces what? Once your body starts burning fat, what does it produce?
Sugar.
Yeah, but it's like, now you have a truck, right?
Mm-hmm.
Okay, and it's a gasoline truck, right?
Yeah.
Are you gonna put diesel in it?
No.
Come on, try it. It's fun. Just save yourself about $1,000 so you can fix it. But
No.
burning fat using fat metabolism causes ketones and acids to be formed. So you become a diabetic keto. You develop diabetic ketoacidosis from burning fat. That's why I told you that when you go into these diets like this ketone diet. So I think back then used to be the Atkins diet. You have to check to make sure that you're not going wild with your ketones and acids. So you have to do a urine test to make sure that you're not becoming ketoacidotic, because now you're burning up the fat and you're looking skinnier, but your body is very susceptible and acid changes in your system. So basically, with diabetic ketoacidosis, I need to enlarge this. Man. It's too small on my computer. Okay, so basically, the pathophysiology behind it. Yeah, the cells signal the body to actually that they actually need glucose. So it releases glucagon. Okay. Uh, Lack of insulin doesn't allow glucose to enter into the cells. Okay. So basically now the large amounts of water are actually excreted by the kidneys because by becoming dehydrated. I mean, that makes you become dehydrated. And the glucose being large molecules draw large molecules of water. So the ketones and excess glucose get into the urine. Okay, because cells still can't get glucose, the body begins to metabolize fat, which basically produces ketones and acids, and whatsoever. Okay. Hyperglycemic condition, diabetic ketoacidosis, the pathophysiology of diabetic ketoacidosis. Factors that can actually lead to it are infection, inadequate insulin dose, certain medications, physical stress, an increase in carbohydrate intake. Assessment findings of diabetic ketoacidosis. Signs and symptoms are produced primarily by the dehydration and acid buildup. Diabetic ketoacidosis prognosis, slowly over a few days. Basically, it's gonna take that amount of time. Okay, assessment findings of DKA. Signs and symptoms related to dehydrations and polyuria, polydipsia, and poor skin turgor. This is what we call the TENT test. Tachycardia and positive tilt test. Now, why would they have tachycardia? Because they got scared of seeing you, or they got happy to see you. Nah. Basically, you get tachycardia because you're losing a lot of fluid. so your blood pressure is going down. So it's a compensatory mechanism. You guys remember what the tilt test is?
The what? The tilt test?
Yeah, you guys do it all the time. You just probably don't know what it's called. As you have somebody lying flat. Let me see if I can find it. You have somebody lying flat on the stretcher or on the bed. They take the blood pressure. Then you elevate them about 45 degrees. You take a blood pressure. If the pulse goes up, and the blood pressure goes down, I'm sorry, BP. If the blood pressure goes down, then they're positive for this, because if they stand up, they can actually faint. Nausea, vomiting, and muscle cramps are typically due to electrolyte disturbances from the loss of sodium, potassium, and magnesium. But why is it that you're losing sodium, potassium, and magnesium?
It's in your blood.
It's in your blood, but you're losing it in your kidneys because you're getting dehydrated. So you're urinating it out. See how the body works in not so mysterious ways? Okay. Hyperglycemic condition, diabetic ketoacidosis, emergency medical care, establish and maintain an open airway, administer oxygen and SpO2 levels above, when you have less than 94, but you want to maintain them above 94. Positive pressure ventilation if needed. Determine the blood glucose levels. If you are not sure of the condition, administer oral glucose. Like what I told you, if you're not sure, give them glucose. Contact medical direction for advice. So now we have hyperglycemic condition, hyperglycemic hyperosmolar syndrome, which is the blood glucose levels now are 600 to 1,200. And the previous one, in diabetic ketoacidosis, they were above 300. And in this one, they're above 600 to 1,200. Glucose is excreted in the urine in large amounts of water. So they have a hyposmolar effect and dehydrate you also. There is enough insulin present to allow use of glucose to prevent ketones production from use of fats for energy, which is non-ketotic. And it carries a high mortality rate. It can kill you. Give me a few seconds. I need to mark something like this. Okay, so basically what happens, I need to move this now. Some insulin is available, which allows small amounts of glucose to get into the cells. But then you have large amounts of water are excreted because, remember, glucose is a high molecular structure, which causes the kidneys to urinate and bring a lot of water with it and whatsoever. So, assessment findings of hyperglycemic hyperosmolar syndrome. Signs and symptoms are similar to those of DKA. No significant buildup of ketones in the body, and therefore no significant acid load. They have no Kussmaul respirations. Now, Kussmaul respirations is what you're going to get when you have diabetic ketoacidosis. And those are very deep and fast respirations. And the reason your body's doing Kussmaul respirations is to actually get rid of the acids. So you get rid of moisture when you're breathing out, right?
Yes.
Okay, emergency medical care, establish and maintain an open airway, administer oxygen if the SpO2 level are below 94 and you want to maintain it above 94, provide positive pressure ventilation if breathing is inadequate. Emergency medical care, check blood glucose levels. If you're unsure of the condition, administer glucose if the patient can swallow. Contact medical direction for advice. Now, here are the different symptoms that you're going to find when you have diabetic ketoacidosis, hyperglycemic hyperosmolar, and hypoglycemia. In onset, you have slow over days, and sudden over minutes when it comes to hypoglycemia. The heart rate is going to be tachycardia in all three of them. Blood pressure is going to be low, low, and normal with hypoglycemia. Respirations, you're going to find Kussmaul respirations and diabetic ketoacidosis. And you're going to find normal respirations and normal to shallow respirations and hypoglycemia. You're going to find a sweet and fruity smell from the ketones and nothing on the other ones from diabetic ketoacidosis. Mental status, you might actually be in a coma in the late stages. You have confusion and bizarre behavior, agitated, aggressive, altered, unresponsive. Oral mucosa is going to be dry and all, well, on two of them, and the hypoglycemia, you're going to have salivation. Why? Because hypoglycemia triggers epinephrine release. Thirst, you have an intense in both of the first two and absent in the third one. Vomiting, it's common in diabetic ketoacidosis and hyperosmolar also, but it's uncommon in hypoglycemia. Insulin level is going to be low, but insulin levels are going to be high in hypoglycemia because you might actually be insulin resistant. So now you have a lot of insulin in your system that's not being used. Glucose levels above 350 and diabetic ketoacidosis, above 750 in hyposmolar, and actually low in hypoglycemia. Basic care, yeah. Go ahead.
I just like thought of it right. Is it very common for a lot of like, 'cause since diabetes is super common down here? Because I know because my CS and shit, like if we scare them, they get mad and they're like tell us like stop, I'm diabetic. Like I could
Oh, they actually tell you
like
that?
my blood sugar will drop.
Yeah, that's one
So
of the, I mean, they might have heard it somewhere along the way. It's not something normal that we talk about, but yeah, I mean, they might have heard it.
So even if
you know how
like,
your tias are all chismosas? They talk to each other.
yeah. Mhm.
Yeah, I mean, that could be the reason that they're actually telling you because they, you have the release of epinephrine.
So my question is like, can somebody just become hypoglycemic if they're like in a, like, let's say a car accident and it scares them really bad, but they just happen to be type 1 diabetic?
Okay, and I'm gonna tell you this, and this is a Mexican thing. Okay, me being Mexican. When I was a kid, and we would get terrified of something like a dog came at us or somebody dressed as, I don't know, Freddy Krueger or something and jumped us. What did your grandmother do to you?
Gave us sugar.
Yeah, they would get a spoon, they would put it in the sugar deal, and they will give it to you because epinephrine causes hypoglycemia. But I mean, it's not. I don't think I ever needed the sugar when I got scared. I like getting scared. So I don't know. I mean, they could be, but I mean, remember that they gave you glucose. I mean, not glucose, sugar for la cura del susto.
Yeah.
Of course, little old ladies follow it up with a bathe, and they're bathing in alcohol, which is isopropyl alcohol, which is the rubbing alcohol.
Yeah.
And then you go there, and they smell like alcohol, and you're wondering, say, well, it's not, doesn't smell like beer, but it smells like rubbing alcohol, and you're scared to light up something. But ideally, what it does, it once you put alcohol in your body, it cools you down. It causes you to cool down. So, patient actually for DKA, they need insulin. Now DKA and this one, it's both insulin and fluid, and glucose for hypoglycemia because they need sugar. Scene size of primary assessment. Look for medical alert tags, tattoos, and other medical identifications. An insulin pump is a clue to diabetes. Now, now what they do is they have these little insulin pumps that they paste onto them, and they're walking around with them. And whenever the blood sugar levels drop or go high, the insulin pump releases insulin. This is what the medical alert tags look like. I've seen them in stores. I just never seen somebody wearing it. History and secondary assessment. Remember, you have to take a sample history. And what does sample stand for? Signs and symptoms, allergies, medications, and all this good stuff. Especially ask about medications taken for diabetes. If you find insulin inside the refrigerator because it needs to get cooled, somebody in the house is a diabetic. As the following in the secondary assessment, has the patient taking their medication? Has the patient eaten their regular meals? Has the patient vomited? Or has the patient had any unusual physical activity, like they started exercising? Elderly patients with history of secondary assessment, elderly patients frequently suffer signs and symptoms that mimic a stroke, such as weakness and paralysis of one side of the body. Keep in mind that some medications, like beta blockers, can actually hide the signs of hypoglycemia. Establish and maintain an open airway. Administer oxygen if the oxygen levels are below 94. Provide positive pressure ventilation if breathing is inadequate. If the patient is able to swallow and has a low blood glucose level, administer oral glucose and then transport these patients. Okay, reassessment. Determine if the administration of glucose has improved the mental status. So if you give them sugar and they start getting out of it, yeah, this may actually take about 20 minutes. If the mental status does not improve, consult medical direction about administering more glucose. Consider other causes of altered mental status. And what are the other causes of altered mental status?
Shock.
Shock. How about stroke? How about heart attack? And a whole bunch of other stuff. But you might want to consider it. But you already know, if this person's a diabetic, then chances are that's the problem. Okay, so we're done with the lesson today. You guys have any questions? We're just going to cover this chapter today because it's a lot of information, believe it or not. You need to absorb it.
Yeah.
So what I'm going to do is I'm going to let you go, and then we're going to go ahead and meet on Monday, the day before Tuesday. You thought I was going to say 4th of July, right? For Tuesday.
All right, so have a good weekend.
You too. Behave yourselves.
Yes, sir.
Did you sign up for Danny's class?
The what?
Did you all sign up for Danny's class?
Yeah, it's not till November. I read it wrong.
Okay, no problem. I mean, he can teach that class very good. So
Okay.
I would go ahead and just take the class. And if it's free, con más ganas.
Yeah.
All right.
Alrighty,
Then
sir.
I'll see you on Monday, guys.
Yes, sir.